This Fed Gov Today program is sponsored by Maximus. On this edition of Fed Gov Today, an early warning signal for the Veterans Health Administration.
The primary concern was that there weren't safeguards beyond the primary processes.
VA Inspector General Cheryl Mason on Fed Gov Today in just a moment. Uniting program strategy, advanced technology, process, and execution for a more efficient government. That's Maximus. Every program, every service, every time. That's innovation forward. Learn more at maximus.com/federal. The Veterans Health Administration says it'll expand the use of its ambient AI scribe to all of its facilities this year. It's a generative AI application that takes notes while patients talk to providers. The Inspector General's office, VA, though, has an early warning for VHA about its use of generative AI. Cheryl Mason's the Inspector General at the Department of Veterans Affairs. Cheryl, it's great to talk to you again. Thanks for joining me today. What prompted you and your team to want to take a look at how the VHA is using generative artificial intelligence? Welcome.
Thank you, Francis. It's nice to see you again. It's nice to be back with you. Well, the department's been using VHA. VHA has been using this really since late 2023. So we've kind of been aware, but we wanted to take a look at how they were using it around clinical care and documentation. It wasn't prompted by any allegations. It was really just, there's a lot going on in the world of AI. We wanted to understand, and that's part of our oversight. We want to make sure that we know what they're doing, we know how they're doing it, whether it's effective, whether it's efficient, and we understand the environment in which they're using these tools to help care and treat veterans.
The VA has been at the forefront of using artificial intelligence in healthcare. The VHA has been, and I've talked to a number of folks over the last several years about the way that they're using them. What did you find when you began this investigation about exactly what the use cases look like on the front lines of caring for veterans, Cheryl?
Well, basically, and to be clear, we're still in the final analysis of this report, and it should be out in a month or so, maybe two, as we finish up our analysis here. But really, what we found is while they're using it, the primary concern is, as I think we've all heard, is that AI hallucinates. Right? And you put a lot of information in and it gets confused, or it hallucinates and gives you back information. And the primary concern was that there weren't safeguards beyond the primary processes to report these. So, normally in VHA patient safety areas, there's ways to report a near miss or concerns or a high impact issue. And but those AI, how they were using AI was not provided as a categorization to that. And so what our primary concern was in issuing this, just heads up alert, is that, hey, you might need some more tracking on this and ways for your people to report that it's not working. And there were no patient safety incidents that we found initially. It was just the concern for that.
I note from this preliminary result advisory memorandum that your team writes, VHA authorizes 2 general purpose AI chat tools for use with patient health information, VA-GPT and Microsoft 365 Copilot Chat. It sounds like what you're referencing, though, is not reflective of the tools themselves. It's reflective of the general technology of generative artificial intelligence. Am I reading this the right way?
I think that's accurate. I mean, we have to remember that how VA is using it is very condensed to their world. Like, they're not using like ChatGPT on Google or something like that. It's very contained in the firewall and things like that. So we're not talking about a situation where they're just going randomly and using information. It's a contained system. So really, but yes, you are correct in saying that the process around the use of the tool, because again, it's a tool, right? Like any other tool, is the way to kind of make sure that we have checks and balances on it was not adequately supported. And that's something actually we're currently working with VA on as we do this report. They've been very responsive to during our discussions with them, and I think they're already making some changes to address this. So our report, when it comes out, will acknowledge those changes.
You referenced the governance that's already in place inside VA. There are two organizations that your team cites here, the National AI Institute and the Office of Information and Technology, OIT, inside VA. How does what you have looked at so far comport with what their governance policies and procedures are?
Well, I think it comports with it. It's the primary concern is the National Patient Safety Group, right? Is ensuring that that they have awareness of it and are tracking it, but also in IT, so that IT is tracking as well, so they can help support that on that communication side, seeing where the glitches are or where something's not working. And so those are the two areas that I know on the IT side, they're definitely working on that. And it's my understanding with the Undersecretary of Health, when I last spoke with him earlier this week, that they're looking very closely at the patient safety piece to make sure they're collecting this information and putting it in the right categories to ensure that it is being tracked and addressed. So they're working to create the governance around this tool that needs to be there.
I read from this memo, and we'll put a link to this memo on the show page so folks can see it. The OIG is concerned about VHA's ability to promote and safeguard patient safety without a standardized process for managing AI-related risks. Is it the policy of OIG to have a thought about what those processes should be, or just to acknowledge the fact that those processes should exist and the VA should then implement them in some way?
Yeah, so our primary role is to recommend that they put something together. We don't really tell them what to put together. That's up to them under their protocols and their processes. We just point out that, it would be beneficial and really important to veterans to have that. But we don't tell them what to do. We just recommend.
This is usually the time in an oversight conversation, Cheryl, well, I'll say where I will ask what you will track moving forward. And I think that's particularly insightful based on the fact that, as you said, you called this a heads-up alert. I cited the title as a preliminary result advisory memorandum. It's not a full report.
Right.
How does that inform the way that you will continue to do that final analysis that you talked about that you're still involved with to then release the finished product, essentially?
So part of the reason we don't issue a lot of these are not unicorns for us. So we only issue them in cases where we have considerable concern about, significant concern about issues happening. And so in this case, the complete report should be ready in the next 60, 90 days ish. And so, but while we go through that process, we're still talking to VA the whole time. Right. So we're talking to VHA and they're responding to this PRAM, and they're doing some things. So as they make those changes, we'll acknowledge what they're doing. And then when we issue the report, we will acknowledge what they did. We'll have, if we have any further recommendations. What happens a lot of times, you'll see us do this on our cyclical healthcare reports. We'll go into a facility and we'll start to do the cyclical inspection, and the facility will change something while we're there because we pointed something out. That's exactly what's going on here. And so in those cases, sometimes we don't have the recommendation because they fixed it, right? So it could be that our recommendations aren't going to be as big as they once were because we gave them this heads up and they can get ahead of it. But the other part is, whatever recommendations we do have, we will follow up on. And so we follow up on our recommendations within like 30, 60 days. We go back to VA, we knock on the door, what are you doing? What have you changed? And they come back to us and tell us what they're doing, and then we can close those recommendations as we find out they met what we recommended, or they addressed what we had concerns about.
Either specifically related to this one or more broadly to the concept of the PRAM in general, How do you determine that something rises to the level of need for you to do something like this versus, well, it's a concern, but it's something that we can wait to address in the full report?
Well, I think the reason we moved to the PRAM, especially in this case, is as I came in the door, we were working to, and VA is changing like crazy. There's a lot of transformation happening. We wanted to make sure that we were able to give VA the heads up while their transformation is underway, so we can address that. And because we were also transitioning how we do our reports to be more agile and timely with our reports, it kind of all came together that this was the proper methodology to use in this case with the follow-up report coming. I think as we move forward, you will see our reports become more timely and more agile in response to what the department's doing, and therefore we probably will not be issuing as many PRAMs because we'll be more timely and agile with the department. And that also goes to our ongoing communication with both the department and our stakeholders, including the Hill. As things come up like this, we have the duty to notify both the Secretary and Congress. And so we do both of those things through our reports. And the one thing that I think is very important for both entities is they want to see our recommendations. They want to see what we looked at, the data, the information, and why. And we can't do that in a PRAM. We have to do that in a report.
Cheryl, it's great to talk to you again. Thank you very much for your time today. I appreciate it.
Thanks, Francis.
You can find a link to the work Cheryl told you about on today's show page at fedgovtoday.com. Don't forget, Fed Gov Today TV debuts at a new time every Sunday morning. You can see the new show Sunday mornings at 10 a.m. on ABC7 in Washington and on YouTube. If you missed the debut, you can watch on demand on the Fed Gov Today YouTube channel and on fedgovtoday.com. The next Fed Gov Today podcast comes next Tuesday. I'm Francis Rose. I'll talk to you then. Thanks very much for listening.